Welcome, everyone. This is my first radiology Zoom lecture to the department, so we'll see how this goes. Normally, I like to put you guys all on the spot, so consider yourselves off the hook today. Sam asked me to do the talk, and he said he really would like a review of community orthopedics, and so I decided to oblige him as a Christmas present. Unfortunately, I have no disclosures. If you have any opportunities, I'm always happy to oblige. So what are we talking about today? We only have half an hour. And so I figured rather than going through an exhaustive, like how to read, a chest x-ray or something like that, what I figured is we would just really focus on some high yield orthopedic cases that you will likely see out in the community. Many of these are subtle, but have pretty bad outcomes if we don't treat them right. And also many of these will show up on your in-service, so it's probably a good time to review some of these injuries. So our goals for today, we'll talk about some of the limitations of plain films, particularly in orthopedic radiography. We'll talk about some of the common pitfalls in interpretation, and I want to talk about some of the high-risk orthopedic injuries and their findings. Stuff to scare your pants off. These are, many of these are serious injuries, and they can have very, very subtle findings. And when you look at closed claim data, missed fractures are almost always at the top of the list for why we as emergency providers get sued, and also for radiologists as well. And there's a couple of reasons for this. Reading x-rays is hard, particularly orthopedic x-rays. And why? What makes it so hard? Well, basically what we're trying to do is we're taking a three-dimensional structure and viewing it in 2 dimensions. And a lot gets lost in translation when you do that. My kids are asking for Nintendo for Christmas. So I have Mario on the brain, so I apologize. This is a great example of that. And so if you take a first glance at this, it looks like the lion's eating her baby. But when you look at it from the other side, you see that she's nourishingly carrying her cub. And this highlights a common saying in radiology and in orthopedics, which is one view is no view. And so one of the basic concepts is when we're trying to take that 3D structure and look at it in 2D, we really need to look at it in different planes. This is another very often quoted example of one of the princes. So one view is no view. So we always need to image in at least 2 planes, if not 3. And the reason for that is there are a lot of overlapping structures. This is a foot x-ray, and I find that feet are probably one of the hardest x-rays to read just because there are so many overlying structures sitting on top of each other. And you can have pretty bad pathology that hides because of it. And there's also a phenomenon. If you look here, this is a odontoid view of a C-spine. Not something we do much in adults anymore, but certainly in kids we do. And if you look at this, at first glance, it looks for all the world like there's a type 2 dens fracture running right across the base there. But what this is really an optical illusion called a mock line. And it happens when you have bone overlying bone, and it creates what looks like a lucency and can look for all the world like a fracture, when in reality it's just overlying bone. And the way that you can sort of suss that out is you can see if you can trace out that line beyond the cortical borders, or does it stop right at one cortical border? If it stops at the border, it's more likely to be a break. But that's part of the problem when we have structures with a lot of overlying bone, like feet, wrists, etc. A lot of these subtle fractures can either get missed or blown off. Our patients are also often very osteopenic. So this is a pelvis of an elderly woman who had fallen. And she's really osteopenic. These bones are really washed out. There's actually more calcium in her uterine fibroid than I think in the whole rest of her pelvis. And it makes finding fractures sometimes very difficult. And in fact, this is a hip fracture, and this is the fracture right here, this sort of dense, sclerotic looking band across the femoral neck. So in our osteopenic patients, it can sometimes be very difficult to pick up fracture lines. We also often settle for inadequate views. It seems like orthopedics is constantly on our case. You call them, they look at the films and are like, oh, this isn't good enough, you got to send them back. And there's a reason why they're very particular about the views, because if you don't have adequate views, you can miss stuff. And elbows are a classic example of that. Here, this elbow is tilted, And normally you should see the condyles nicely overlapped on each other, and instead they're splayed out. And that makes it very, very easy to miss pretty serious pathology in the elbow. So don't settle for inadequate views. The other thing is we often read in a vacuum, and especially now in the era of triage orders and trying to improve throughput through the department, what you'll find is that a lot of times x-rays get ordered out in triage, sometimes just even as a protocol order by nursing. And you go and you look at the x-rays and you don't see anything, and then you go tell the patient that their x-rays are negative and you send them home. And that happens not infrequently, and it's actually a cited reason for why we often miss things. When in reality, what we really need to do is use our history and physical exam to influence your interpretation. And there's a famous ER doctor, David Schwartz. He writes one of the textbooks that I really like for the rotation. And he makes the point that fractures are really a clinical diagnosis, and we use x-rays to further characterize them. And so we really should be examining our patients and knowing where they hurt and what their injury is. And that should help influence how we interpret the film. That also makes it really hard for radiologists who are reading in a vacuum, who don't have a physical exam to guide them. And so, you know, as many of you have heard me say, we really should be looking at our own films because we have the best idea of what's going on with the patient. And for many of you who are leaving and going into the community setting, you will be reading your own films, sometimes even during the day. So you got to get comfortable doing it. So let's look at some cases. We're going to sort of rapid fire go through some of these. As we start, one of the things I want you to keep in mind are the ABCs. They work really well in radiology, and particularly for musculoskeletal radiology, they work really well. And it's A for alignment, B for bones, C for cartilage or joint spaces, and then S for soft tissues and spacing. And you want to run those ABCs through your mind as you're looking at these films. And again, because of time today, we're not going to do this on every film, but as a general rule, as you're looking at these, run your ABCs. So this gentleman comes in after a football injury. He's complaining of finger pain. This is an AP view of the hand. As we look at it, nothing too exciting jumps out right at first. But then when we look at an orthogonal view, when we look at the lateral, we see pretty obviously that he's got something going on here. And so this is at the DIP of his ring finger. And this is actually a pretty significant injury. And this is what's known as a jersey finger. And not because of the state, but because what happens is the mechanism for this is a hyperextension of the digit when it's held in fixed flexion. So you imagine as somebody's going to grab somebody's jersey in football or rugby and the tip of their finger gets snapped back, what ends up happening is you end up avulsing your flexor tendon. And so this one has an associated fracture with it. Sometimes it's a pure tendon injury. And the tendon involved is the flexor digitorum profundus, which allows your finger to flex at the DIP. This is a common pitfall because if they don't have the associated fracture, if it's just a tendon injury, the x-ray can look pretty normal. And as you're examining the patient, if you don't isolate out all of their joints, you may miss the fact that they're able to flex at the PIP, but not at the DIP. And so you really do need to do a good, thorough exam. These injuries have actually a pretty high morbidity in terms of function, and the longer it takes to fix them, the worse the prognosis is. And so these are ones that typically need to be fixed pretty quickly. The vast majority are going to involve the ring finger. It's just a weaker attachment. And again, physical exam is really, really critical. A similar injury, this is a guy who came in who jammed his finger playing basketball. Looking at this guy's lateral, it looks at first glance like a very similar injury, except on the extensor side. And what this is a mallet finger. And this is not uncommon. You'll definitely see these. And this occurs when the fingertip is forcibly flexed when it's held in extension. So you can imagine, you know, taking a bad snap with a basketball could do this easily. And again, just like with the jersey finger, sometimes you have the associated fracture, but sometimes it's a pure tendon injury. And again, if you're not very careful in how you examine the patients, you can miss this injury. Thankfully, extensor tendon injuries are much more forgiving than flexor tendon injuries. These are often treated non-operatively. You put them in a hyperextension splint, and their discharge instructions are very critical for this. They need to leave that splint on for a minimum of 8 weeks. if they take it off at any time and move that finger, it resets the clock and it increases the chance that they'll need an operative repair. So discharge planning is really important. So again, mallet finger, hyperflexion injury at the DIP. All right, we're getting into wintertime. Things are getting slippery out there. This lady comes in after a Fuchs injury. This is an AP view of the wrist. Again, at first glance, it doesn't look that exciting. Her alignment looks pretty good. The bones, I'm not seeing anything super obvious jumping out at me. But again, keep in mind, there's a lot of overlap of carpal bones in here. And so you really have to take your time and trace out each of the bones. When we take a closer look at it, this is an oblique view, we actually see a line coming across the waist of the scaphoid. And so then the question is this a mock line or is this actually a fracture? And as you trace that line out, you see it stops right at this cortical border. And then as we come across, it stops at this cortical border. So that makes me very concerned that this is a scaphoid fracture. And this view is a scaphoid view where they sort of tilt their wrist over and it gives you a better look at the waist of the scaphoid. And here it's a little bit clearer. You can see it's actually a little displaced. So these are very common. So it's the most commonly fractured carpal bone that shows up on the boards all the time. And roughly about 2/3 of all carpal fractures are going to be scaphoid fractures. We care about these because if you miss it, it can have bad consequences. And x-rays initially can be negative. And so again, history and physical exam become very important. If you have a concerning mechanism in an exam that's concerning, i.e. snuff box tenderness or pain on axial loading of the thumb, you have to assume that they have a scaphoid fracture, even if the x-rays look normal. If you miss this and they displace that fracture, the incidence of non-union goes way up. And the reason for it is the blood supply. So the scaphoid has a very tenuous blood supply that comes in distally and travels proximally. And if you fracture across the waist of that, you disrupt that blood supply, and then that proximal piece of the scaphoid dies. And when it does, it causes vastly accelerated osteoarthritis, which can be really, really debilitating. And a lot of these injuries are in young people who have a long life ahead of them. And you can imagine if you see this, so this is one that had been missed, and this proximal piece is all shrunken and sclerotic, and you see all of this bad degenerative disease around it. This really, really, really limits mobility and function. And so these are high-risk injuries and are a common source of lawsuits. So again, with negative x-rays and a concerning story in an exam, you're going to put these patients in a good thumb spica splint and get them prompt follow-up in about a week to 10 days for repeat imaging, at which point, if there's a fracture, you should be able to see it. Here's another Fuchs who comes in with pain. And again, this is an AP of the wrist. As we take a close look at the alignment, something seems a little bit off. And in particular, as we look right here at the alignment between the scaphoid and the lunate, we notice that space is wide. And what this is scapholunate dissociation. So in this case, we're not seeing an associated fracture. It's just a soft tissue injury. But again, this is pretty debilitating. And this is an unstable wrist that will usually need operative fixation. And so again, if you're just looking at fracture lines, you could easily blow by this. They call this the Terry Thomas sign. He was a British comedian with a big gap in his front teeth, also sometimes called the Dave Letterman sign. So again, not all injuries have fractures. So a normal scapholunate interval should be less than 4 millimeters. I'm really bad with remembering numbers. So as a general rule, all of your intercarpal distances should be about the same. And we see that this one is about twice as wide as all of the other articulations. So that is abnormal. All right, 10-year-old comes in, he fell while skateboarding, and we see this. And this was actually a case that Jess Smith and I saw at the Miriam on an overnight together many years ago. And there's an obvious break in the radius, but then again, one view is no view. So we do a lateral view to look at it in a different plane. And when we do that, we see that the alignment is a little bit off. And in particular, what's off is the radius is tilted volarly, but the ulna is still pointing up. And, you know, the radiology resident read this on the overnight and they said, oh, it's a, displaced fracture of the distal radius. What they didn't comment on, though, was that there was a disruption of the distal radioulnar joint. And we know that because your ulnar styloid, which is right here, should always be pointing up towards the triquetrum, which sits up here. Instead, it's pointing up off into space, and that's abnormal. And so when you think about it, we now have a distal radius fracture with a distal radioulnar joint dislocation, or an ulnar dislocation, which makes this a Galeazzi fracture dislocation. And I'm not a big fan of eponyms, but these show up on pretty much every board exam I've ever taken, so you just need to learn them. All right, this kid comes in, trip and fall, complaining of elbow pain. Pediatric elbows are incredibly hard to read. Even the radiologists don't really like reading them because of all the different ossification centers. When we look at it, I see a lucency here that catches my eye. Again, is that an ossification center that's supposed to be there, or is that a fracture? There's a whole system to go through that I don't have time to do today. But as we look at it in different views, particularly the lateral, as we take a close look at it, I'm not seeing an obvious fracture on this view, but what I do see are fat pads. And I know these can be a little bit subtle, but right here is a triangular anterior fat pad. And back here is a little bit more loosened area of a posterior fat pad. And so the anterior is what's known as a sail sign because it's that nice triangular sail shape. Fat pads happen because normally in the olecranon and antecubital fossa here, you have fat sitting on top of the joint capsule, and it's hidden by the surrounding bone. When you have the joint effusion, and in trauma that's usually a hemarthrosis, it lifts those fat pads up and out of those fossa, and we're able to see that as darker looking areas on the x-ray. And that's a secondary sign of a fracture. And in elbows, that may be your only sign. And so it's really important to look for them. Getting back to the point of inadequate films, if you do not have a true lateral x-ray, you can easily miss these fractures. You really need a good lateral to be able to see them. Posterior fat pads are always bad. P for posterior, P for pathologic. Anterior fat pads may be bad, but you can also have a normal anterior fat pad. If you have a normal anterior fat pad, it should be nice and narrow and really hug the bone. Once you see it splay out and form that sort of triangular sail shape, then it becomes pathologic. This is what a normal anterior fat pad would look like. It nicely sort of parallels and hugs the bone. Moving on to, so this was a supracondylar fracture. We know that in kids, the most common elbow fracture is going to be a supracondylar fracture. And the vast majority are, extension types from like a fallen outstretched hand. These can be very subtle. And again, those fat pads may be the only indication that we have. I'm not going to go into the types too much. It's more important that you at least just diagnose it.